All right, hi everybody, I'm Jenny McAteer with Resolve Physical Therapy in Bend, Oregon, over on the west side. And we are bringing you another Wednesday Wisdom episode, and today we're going to talk about shoulder injuries in females. So I'm super excited to have Dr. Urch from the center here, and I'm going to let her introduce herself a little more.
Hey everyone, I'm Ekaterina Urch. I am a sports surgeon at the center. Just a little bit about myself. I have a weird name. I was born in Russia, moved to the States when I was 8. Did all my training on the East Coast in New York, and then I did my fellowship in LA in sports medicine, and have been here for 3 years and loving it so far.
3 years already?
Yeah, almost exactly, yeah.
Okay. So female injuries, what do you get to see most often come into your office, would you say?
So in general or sports? I mean shoulder.
Shoulder.
Yeah, so
yes.
So I mean the most common thing I see, I think, is probably what we call, impingement. Just sort of an overuse injury with sort of pain kind of with lifting your arm up. That's probably the most common.
Most common.
Yeah.
I would say it's probably most common we see in here, probably coming from you guys.
Yeah.
But the woman, do they have more risk factors than a man might have for a particular shoulder injury?
I think, that's a good question, and I was kind of thinking about that when you sent me the sort of the lineup for today, and I can't say that there's any specific risk factors, because a lot of it has to do with just, a lot of it is poor posture and ergonomics. Especially nowadays, we spend so much time kind of here that, I think, as I'm sure you get very weak periscapular musculature and everything gets really tight, and so when you try to lift your arm up in that kind of position, you really can flare things up and aggravate the shoulder. I mean, that, I guess a little bit of muscle imbalance, muscle weakness, but I can't say that women are more predisposed to it,
Particularly for those.
I mean, the only thing I could maybe think of is women that are maybe larger chested are more prone to be really sort of
more
much
rounded
more rounded,
shoulders, problems there.
Yeah, yeah.
Is there a more common age that you see?
Yeah, I mean, I think probably sort of middle age, kind of 50s and up, kind of the weekend, especially the weekend warrior set. A lot of people, especially here in Bend, coming in and starting to, pick up pickleball and sort of kayaking, things like that. But that's probably, I'd probably say 50s, 60s is the most common that I see. But I see it, in everyone.
Okay. Some of the ones that we see most often that we have patients asking us the most about, especially in that age range, maybe a tad younger too, but is frozen shoulder. So can you talk a little bit about what a frozen shoulder might look like for someone to be able to kind of recognize what's going on?
Yeah, so frozen shoulder is very common in that, exactly as you said, in that sort of mid, 50s kind of age group. And usually the way that it presents, although, it kind of can vary, but sort of the classic textbook presentation is sudden loss of motion with pain. So it really comes on sort of in the acute phase where it's really painful to really move your arm in any direction. Yeah. And then that kind of leads to a frozen shoulder, meaning that you can't really move, you feel like you just can't move your arm at all. And usually there's no inciting trauma. People come in and they say, I don't know what I did. It just woke up and it started to hurt. And sometimes there's a fall or, an overuse injury, like if you spend the day kind of washing all your windows or something. But more often than not, it's completely atraumatic. You can't really identify what caused it.
Which surprises a lot of people.
Yeah.
They all like to have the answer of why this happened.
There are a couple risk factors. Diabetes is a risk factor. Hypothyroidism, those are kind of the classic two. So I would imagine any kind of, you could maybe extrapolate to like any kind of inflammatory underlying conditions, but really the only two that we know for sure are diabetes and hypothyroid, and we don't really know why.
And that happens more in females, the frozen shoulder, and males in general too, right?
More common in women for sure,
And then you mentioned shoulder impingement as being one of the more popular ones that you see in your office, and a little bit difficulty lifting. Anything else that a patient might be able to look for to see if that's what they might have before they're willing to come talk to you or I?
Yeah, so again, a lot of times the same idea, no real trauma, just started to bother you. I think a very common symptom is, the pain is usually kind of right on the side. So not really kind of shoulder as you classically think of it, but more, if you would think of it, it's more on the upper arm. And a lot of people struggle sleeping at night, like especially sleeping on that side is a very common common symptom. And then of course, people say I can't lift up to do my hair, I can't lift my arm up because it just hurts beyond sort of kind of 90 degree, and this anything above here is really painful.
So all those overhead activities of any kind. And then of course, classically, we're always seeing people within some of these injuries, but also sometimes on its own, is for a rotator cuff. So if you have a tear, what would you tell someone to look for?
Right, so it's tricky because a lot of times rotator cuff sort of pathology or abnormality is kind of on the spectrum of impingement, but a lot of the symptoms are similar. An acute tear, meaning where you really, you think you tore something, usually there's an injury, and that could be it could be trying to lift something heavy that you don't normally lift, like, a common sort of story is I was traveling and I went to try to get my bag into the overhead compartment and I felt my shoulder go. So it's sort of a heavy lift or a reach or falling on your shoulder. So if there's an injury followed by new pain, especially pain at night, and especially if you suddenly, you have the injury and then you feel like you can't lift your arm up. Those are sort of signs to be aware of, and that's probably something that you should get evaluated for. But a lot of people have rotator cuff injury in the setting of impingement, which is then we would define as atraumatic rotator cuff injury. And that usually, I always tell patients 80% of people that come in with sort of that kind of pain with no injury get better without having to have an MRI or any further imaging, so unless there's weakness or signs on exam that are more concerning for me.
And that's a good mention because most people, that's immediately what they want,
right.
is the MRI. So.
Yeah, I do.
But we can do a lot of little tricky tests to kind of tell us a little bit more about what is actually going on. And then rotator cuff tears, we can actually break down, right, to grade 1, grade 2, grade 3.
Right.
And so some of those can be a little bit tricky for people to
kind of,
to decide.
And that's sort of when you start to kind of get into the technicality of it, and that's based on the MRI and, there's, and kind of grade 1 or low grade is it's less than 50% of the tendon is torn. And so what I tell patients, I think a good analogy is it's like, imagine the tendon is like string cheese, and so you have a couple of those fibers have been pulled away, but most of it is still intact. Grade 2 or moderate grade is about 50% is torn, so you're taking half of the string cheese and giving it to your kid, and then high grade is more than 50%, which sort of in my mind a lot is a lot of times if I see that on the MRI when I actually go in and operate, it's essentially a complete tear. There's a couple of fibers still intact, and that really helps me sort of know whether I think that conservative care will help.
Exactly.
So if we're at that point where you get an MRI because things aren't getting better or because there's been an injury, and we can kind of look at the grading, then I can say, well, I think we should just throw in the towel and fix it, or no, let's get you back, let's keep going. I think you can recover without surgery.
So that almost gave us a little peek inside the next question, but one of the concerns we sometimes get with people when we try to refer them onto you is they think that you're going to immediately want to cut on them. So.
I pretty much walk into the office with a scalpel. So.
Beware. So what would like a first visit look like with a specialist on a shoulder injury?
Right. So obviously I ask a lot of questions, physical exam, very thorough. I always look at the neck because the neck, there's a lot of overlap with neck pain and shoulder pain. You want to make sure that you're not missing something in the neck. And then I have a discussion, kind of what I just said. Has there been an injury? If there is an injury, I'm more likely to get an MRI, especially if there's weakness on exam. If there hasn't been an injury, most of the time I don't even get an MRI. Most of the time I say, whatever it is, I think we can get you better without, any kind of further intervention. If you're having a lot of night pain, I might consider giving you a steroid injection just to sort of, I always say it's like pouring water on the flame to kind of really calm it down, get you on an anti-inflammatory if you're able to take it, like an ibuprofen or Motrin or a prescription version of that, and then get you over, get to you guys.
So some physical therapy, like that.
Yeah.
Now, do they need a referral to come see you since you are considered a specialist?
So I think it depends on the insurance.
Okay.
Yeah. So some people's
Typical.
insurance you can just call and schedule. Some
Okay.
people need a referral from their primary.
Okay. It's definitely usually like Medicare and Medicaid, and those guys all
Yeah.
need referrals. But some of
Usually.
the other, and that's kind of how we are. We get
Usually commercial insurance you can just call.
direct
but,
access, right? Too.
Yeah, I think
okay.
so. Yeah.
And that's kind of how we are, as well. So. So if surgery is not the answer, she is capable of doing some other interventions. And so, like she said, she can refer on to physical therapy. So usually you'll come try a stint of PT with us, 4 to 6 weeks, something along those lines, to see if we can get things a little bit better that way. And then sometimes you get the cortisone injection, which, like she said, is just a big anti-inflammatory. Basically, it's going to kind of put out the flame a little bit. Sometimes people are hesitant on that as well.
Yeah.
Bad side effects of those things for...
So, I mean, the biggest sort of acute thing that we worry about is infection. I mean, hypothetically, a steroid is an immunosuppressant. So, especially if you're, it doesn't really get into the body, but if you're injecting, you're putting a needle into a sterile space in your body, there's always a risk that it can contaminate it, and drag some of that bacteria into that space. But I've got to say I do this a lot, and I've yet to have one infection from that. Knock on wood, don't jinx myself. But
I don't think I've heard of one.
It's very, very, very uncommon. But that's hypothetically the big risk. And then, really, the main thing that I worry about is in the setting of if we're thinking that you might need to have surgery down the road, especially younger patient, I'm not as excited about injecting steroid because it can actually weaken the tissue. And so, ideally, you don't really want to do too many. Some patients are sort of, the cat's out of the bag. You have bad arthritis or you have a really bad rotator cuff tear. And so we're not really worried, in terms of damaging the tissue further, because the only real answer is a shoulder replacement, which is kind of a whole other topic on its own. But, but generally, those are the two things. And so, I really have to think about, is it worth to keep injecting steroid, or can we, do something else? And usually, honestly, I think in that situation where it's like an impingement type of picture, I think the most I've ever done is 2 before getting an MRI. Usually, because at that point the patient's also kind of like, all right, I don't want to keep doing this. It's kind of like the definition of insanity, just doing the same thing, expecting a different
outcome from it, which is why we sometimes have to tell patients about that it can weaken the tissues, or that there are limits to, usually I say like 3 injections per joint per year at most.
Right. Yeah. I mean, part of that is you can't have them more than once every 3 months because, again, of the risk of infection. And so, but ideally, especially in a healthy joint or tissue where, there might be surgery down the road, I don't like to do more than 3.
Yep. And that's how, so some of those people that don't mind an injection need to know that. And then some of those people who are a little more hesitant to get one, they call it a Band-Aid. How do you answer that when people call it a Band-Aid?
Yeah, I get that a lot. And so the answer is, and as I said, 80% of the time, it's not. It actually can help get rid of the inflammation enough so that then you can make progress in your rehab. And I always say this, it's really important that when you come to try, if you have this kind of inflammatory overuse injury, you really want to do kind of the tripod of care where it's stop doing the things that are making it hurt, right? So you want to stop doing overhead activities, stop playing tennis, stop swimming for the interim. And then you want to get some sort of an anti-inflammatory on board. And so usually I always will prescribe an oral and then plus or minus the steroid shot, which is a very powerful version of that. And so what that does is facilitates your guys' job. Because I always say if you just come to the therapist with no anti-inflammatory on board, it's like you're tying one of their arms behind their back. Because every time they do something, it's going to hurt. And so you're not going to be able to make progress, know. And so I think in some situations, it certainly is a Band-Aid if you have terrible arthritis or, if you gotten a couple injections and it keeps coming back. But usually all it takes is 1 or 2 and then you're good and recovered. And that really helps.
And it does. And that's what we usually tell people is that it helps the PT be able to progress you and make your time much more worth it while you're here if we have a happier environment to work with. Or if you get symptoms back right again, it can almost be used as a diagnostic too, kind of show you well, maybe this isn't going to work for you, so let's try something else. So those usually we tell our patients too. And then of course, worst comes to worst, sometimes you do need surgery. They probably have a decent relationship with you before that point happens, unless there's a traumatic injury. So in general, do you prefer that they, as soon as they have pain, they show up to you, or that they see their primary first, or it doesn't matter?
So I don't really mind. You know, I think that the only time that it might just make sense to wait is if there's been an injury, you know, like a traumatic where you fall.
Yeah.
And obviously if you think something's broken and you're really concerned, then, you know, just come and get evaluated. But if, you know, if the x-rays are normal and the fall happened, you know, yesterday, you know, I usually would say, well, let's give it a week and see where you're at. I mean, sometimes I'm like, I'm really concerned, let's get an MRI. But usually, especially if, you know, based on your exam, everything seems to be largely intact. A lot of it could be, you know, contused muscle, so bruised muscle, or what we call pain inhibition. And so before jumping jumping the gun and getting imaging and shooting you up and everything, I say, let's give it a week. I'll see you in a week. And if it's still not getting better, you know, or, you know, then we can consider doing something else
from them.
But other than that, I'm happy to see you. It's great, you know, when you've seen, you know, a primary care doctor and they've gone through the paces. You know, and the funny thing is, kind of a side note of that, is I do see a lot of patients that come and say, well, I've gotten a bunch of injections and nothing's helped. Or I've gone to therapy and it hasn't helped. And that's sort of, a lot of times they haven't done the things together. And I'll say, well, you know, what's important is you want to do everything together.
Combo.
Yeah, so.
Okay, perfect. Anything else you would like a good old female patient to know with shoulder pain that would maybe come see you or I?
I don't think so. I mean, honestly, a lot of it is sort of when in doubt, just come see us, you know. I promise I won't send you to surgery.
Yeah. I know, the answer for us usually is it depends. So please just come see us. Let us do our examination. PTs and doctors actually work together probably more than you think. And so we will work as a team to kind of get you better, get you through what we need to. So if you have any questions, feel free to comment, feel free to email us, and we'll get back to you with those. So thanks for chatting with us.
Yeah, thanks for having me.
Yes, you're welcome.